Welcome everybody to this week's case. Here's our clinical vignette. Feel free to pause the video and take a closer look at these symptoms. Let's move on to the ECG. And again, as we say with every video, it's very easy to make a spot diagnosis, but we have to stick to our system. So let's start with rate. Looking at this rhythm, it's very easy to see that it's irregular. And so we don't want to use the 300 method. So we're going to go to the 10-second method instead. Taking our rhythm strip down here, let's start and count the beats. 1, 2, 3, 4, 5, 6, 7, 8, 10, 11, 12, 13. So 13 times 6 is 78 beats per minute. And since our rhythm is irregular, we have to verify that with our paper method. So we're going to take our piece of paper and notch 3 R waves. And we're going to move that along and see if it matches up. So those 3 match up. Those 3 don't match up so well, and then these 3 don't match up at all, and on and on. So we can see that that's irregular. Not only is it irregular, but it has no pattern. And so we can call that irregularly irregular. Looking for P waves, we're going to have to take a closer look at a few leads here. So we see what might be a P wave here, but we don't see one here. Maybe that's a P wave. That might be a P wave, but if we look here, we're not sure. And so what we see as we go through in different leads is that while this looks like a P wave, the same thing is not present here, nor is it present there, nor is it present up there. Okay, so P waves seem to be absent despite the isoelectric line being quite chaotic. For QRS complexes, we can take any one, and again, we want to see how wide it is. That's 2 boxes, so that is less than our 120 millisecond limit for a normal QRS complex. For PR interval, since we can't identify P waves, we can't identify a PR interval, so that's not applicable. As for the ST segment, here's a nice ST segment here, and it's on the level of the isoelectric line. ST segment, so the ST segment there is normal. So in summary, the rate is about 78 beats per minute. We can see that the rhythm is irregularly irregular. P waves are absent. QRS and ST segments are normal. We're not looking at the PR interval since we don't have P waves. These two features together, slam dunk atrial fibrillation. So what's the pathophysiology of AFib? Importantly, the atria are beating chaotically. What causes AFib is sometimes a little bit misunderstood, but it always begins with an initiating event and is maintained by a certain feature of the heart, often a dilated left atrium. So either one or multiple foci inside the atria cause small re-entry circuits. But unlike a flutter, many places inside the atria are doing this all at the same time, which gives you that chaotic isoelectric baseline. Some interpretation tips for AFib. The rhythm is classified as irregularly irregular. There are no P waves. The P waves that do get through the AV node create a ventricular rate that is unusual looking, but is often tachycardic between 110 and 160. Importantly, because the beat is going through the AV node, the QRS complex is narrow, so less than 3 small boxes or 120 milliseconds. Zooming in here, you can see different kinds of isoelectric line morphologies. Some are very obviously chaotic and some are a little bit more subtle. Let's take a look at some examples. Here's AFib with a slow ventricular response rate. So again, we can never count rate with our 300 method, so we have to use the full 10-second method. So we count here how many R waves? 1, 2, 3, 4, 5, 6. So that's over 10 seconds, so times 6, this is 36 beats per minute, and there's a bradycardic ventricular rate. A rapid ventricular response, we would do the same thing, count all these R waves, multiply by 6, and that would give you a tachycardic response. This is an interesting case because you might be tempted looking at AVR and V1 to call this a flutter due to this sawtooth appearing pattern. But importantly with a flutter, that sawtooth pattern will be visible in all leads. If we look at the rhythm strip and the precordial leads, we clearly don't see that sawtooth pattern here. We see no distinct P waves, and we see an irregularly irregular rhythm here. And so we can safely diagnose this as atrial fibrillation. So what are some takeaways for this? AFib is the most common sustained arrhythmia, so it's very important to be comfortable with this rhythm. The lifetime risk over the age of 40 is about 25%, so you will see it a lot. The words irregularly irregular are almost exclusively reserved for atrial fibrillation. Now, it may be difficult to notice a chaotic isoelectric baseline, so this isn't the primary feature you should use for diagnosis. The main things are, as we said, an irregularly irregular rhythm and absent P waves. Once you have those two things together, you can pretty safely diagnose AFib. Thanks for watching again, and we'll see you in our next video.